Lights, everybody.
Yes, you're good.
Beautiful. All right. Well, our topic for today is first things first, patient selection and office flow. And I hope there will be something for everyone, whether you're new to buprenorphine or old to it. And there certainly was, every time I think about this topic, there's something new for me. Here are our global objectives, and here are our objectives for this learning session: to review the indications for MAT and which patients are appropriate, which is a little bit of a loaded word, as we'll see. Consider potential barriers to treatment and how to overcome them. Review the structure of an MAT visit that meets clinical and regulatory requirements, and reflect on our own practices concerning these objectives and issues for our patients. So if we look first at thinking that if we're going to provide treatment for people, we want to know that that treatment is indicated, whatever the problem is and whatever the treatment is. Here are indications for medication-assisted treatment from the point of view of the medications that we use. Methadone and buprenorphine naloxone are actually approved to treat not opioid use disorder, but opioid dependence, which is a feature of moderate to severe opioid use disorder. But you know, as we know, it doesn't define that use disorder, and there are many patients out there who are opioid dependent, physically dependent, without having an opioid use disorder. Extended release injectable naltrexone, that's Vivitrol, is approved for something different. It's approved to treat alcohol use disorder, and it's approved to prevent relapse to opioid use disorder, which is a little bit different. It's assuming this is a person who is in recovery, is not dependent on an opioid anymore, and now is going to be having long-acting naltrexone. Since that patient who's opioid dependent can't convert to long-acting naltrexone without becoming non-dependent on their opioid. Short-acting oral naltrexone is approved to treat alcohol use disorder. It's approved for the blockade of exogenous opioids, but it turns out not to be all that effective for people who are opioid dependent or who have opioid use disorder. There's our friend naloxone that reverses the effect of opioid overdose. Those are indications for use of those medications. We are really interested in seeing which of those patients who have opioid dependence have a diagnosis of opioid use disorder. Those are the people that we really want to treat. To do that, the kind of easiest thing to do is to use DSM-5 criteria, that list of 11 criteria. It's yes or no to all of them, and it's easy to score so that we know that a patient will fall out as having either no opioid use disorder, that's a score of 0 or 1, or they may have mild opioid use disorder, or if they're coming in at 3 to 4 to 5, moderate opioid use disorder. 6 or more on that list would define severe opioid use disorder, and those are the patients generally who are seeking treatment with buprenorphine. Part of our diagnostic process can be identifying from a person's history and their medical records comorbidities. We want to know that those are going to be compatible with medication use and participation in the program, and those can be medical, psychiatric comorbidities or chronic pain. On that topic of chronic pain, as one of our participants mentioned earlier, there are also buprenorphine products that are indicated for treatment of pain, not for opioid use disorder, and Belbuca is one of those. It's an oral patch. The other is Butrans, which is a transdermal patch. Those medications can be prescribed by any physician who has a DEA number. The waiver isn't required for those, and all of the rules that pertain to treating patients with buprenorphine for opioid use disorder don't apply in that situation. The rules that would apply for patients who are treated by an opioid would. Our next step is that we can consider some of the aspects of the patient that would seemingly suggest to us whether they're going to be appropriate and successful in our program. So that first issue is, does the person have a diagnosis of opioid use disorder? They should, in order to participate in our program. Although we do see physicians who are using those buprenorphine products designed for opioid use disorder to treat people with pain. The preference would be to use one of those preferences, one of those products that's really designed for pain. Is the patient interested? Since a lot of what they do is going to be voluntary and driven by themselves, we're not going to be with them 24 hours to make sure they're taking their medication or really going to their meetings and getting something out of them. So we want to know that there's interest. Does the patient understand risk benefits? Are they expected to be reasonably compliant with our rules and requirements? Will they follow safety procedures? Probably should be closer to the top. Are they psychiatrically stable so that they are able to have capacity and consent? Is the patient using other medications that might interact in a bad way with the buprenorphine? Do they have a stable and supportive psychosocial setting? Well, we can consider these things, but you're already likely thinking about patients that you have in your practice and thinking, every patient does not meet all of these requirements or all of these kind of wish list when they come into treatment. It's really more of a wish list for us than a reality. We're able to know if our own offices are able to provide the resources that the patient needs, or we're able to link them to resources that they would need to have. And finally, we're going to have a patient review our treatment agreement and sign an informed consent for treatment. When we consider those issues, which really come from the kind of recommendations that are put forth when we all have done our kind of basic training in how to prescribe buprenorphine, and if you have to think about how they got there, it's really by kind of expert recommendation, not so much by any evidence. And partly it is that when a lot of that material was created, there really wasn't any evidence to go by. So we know in the medical world, we often will have some sort of experience or expert guidance to guide us until we have some evidence accumulated. So coming next. Meanwhile, we might think about from that list patients who we might expect would have more trouble or have a safety issue in our program, and want to address that before we would start their treatment. So we could think about patients on high doses of benzodiazepine, alcohol, or CNS depressants that might be hazardous combined with buprenorphine. But then we can also think about patients who are using marijuana, cocaine, or other drugs that maybe don't have as clear a kind of hazard presented in combination with buprenorphine. Patients with significant psychiatric comorbidity who are psychotic or who are unable to consent. People with active suicidal and homicidal ideation who come into our office. People who have a history of multiple previous treatments and relapses, where we can either have a sinking feeling or we can have a feeling that we might be the program that is going to be helpful to them. People who have had a non-response to buprenorphine, who've described being on buprenorphine and not being able to be sober. People with high levels of physical dependence that are at risk for withdrawal during their induction. People whose needs can't be met with our existing office resources and who are going to need links, and people, again, who are at high risk for relapse. We might think our office is able to accommodate pregnant patients, and we all should be able to do that. And then to consider medical conditions that might complicate people's treatment. I think almost, no, I don't know about universally, but there's data that would suggest that this idea of patients having a great supportive family and environmental system often is not realized initially when people come into treatment, but we can think if there is there's a potential for people to actually be unsafe in their situation or have their medication be unsafe in their environment. And if we're going to have to work with them to create some systems that will be supportive. So those were initial expert guidelines suggested those might be some of the important things to think about. We actually do now have some data about how people actually, progress in treatment, and it does give us a kind of reason to reflect, I think. Here is a study. It's McDermott. It's in the references, and if anyone would like to read the original study, I can send it on so that we can have it in either, or Kate could send it out to you. So in this study, they looked at a good number of patients to see who was opioid abstinent early in treatment. And here's what they found, that if people got onto a reasonable dose of buprenorphine and they were abstinent from opioids at 2 weeks, at their second week, that about 2/3 of those were likely to be abstinent still at 12 weeks and in 2 of the 3 preceding weeks. So in this study, they did frequent urine screens to look at who was abstinent from opioids. Well, it tells you that people did not achieve perfect abstinence by any means, but that early abstinence was predictive of some abstinence at 12 weeks. Early opioid use in weeks 1 and 2 predicts ongoing opioid use at 12 weeks into treatment, but early abstinence from opioids really didn't predict ongoing treatment at 12 weeks. Even though there was a likelihood of some abstinence, it wasn't assured that initial abstinence would mean that you'd have a patient who wouldn't slide back into opioid use. About 1/3 of the patients in this study did that. The take home there for me is that 2-week assessment might be helpful, and it might be a time to look at whether we need to augment resources, or even if that person is appropriate for buprenorphine as opposed to, say, a more structured program like methadone treatment. So that would be that time where we might think about intensifying a level of care, adding resources, or deciding if we just really need to give time for things to sort out. Here is another study that is, the title of that is Long-Term Retention in Office-Based Opioid Treatment with Buprenorphine. That's what it's about. This one is extending past that 12 weeks into a year. At a year, if people have been able to abstain from opioids and stay with the buprenorphine, all kinds of good things happen then. There's less risk of a future relapse, and there's more likelihood of improvement in a variety of social and health indices. So the researchers picked a year as the time frame that they would like to look at, and ask the question, what patient characteristics are associated with long-term retention? It was a retrospective cohort study, so not the strongest design, but you could see there were a good number of patients in it. And here's what they found, and you might reflect on whether you would expect this or not, from your own patient population. Associated with that 1-year retention were female gender, a psychiatric diagnosis, and advancing age. So the older the person was, the more likely they were to be retained, and patients with a psychiatric diagnosis were more likely to be retained also. It was a surprise to me. Associated with lower odds of retention were unemployment, active hepatitis C, and Black and Hispanic race or ethnicity. Unassociated with retention or non-retention, benzodiazepine use, alcohol, or cocaine use. Those things did not predict whether the person would be retained or not retained. And the reasons for disengagement and dropout were 2. By far the most most common and the best documented was relapse for whatever reason. People just kind of not being able to adhere to treatment and falling away and relapsing to opioids. But the next most common reason for disengagement was actually clinic problems, which implies to me that possibly some of the rules that we've set up or have been set up for us and the way that we structure our program may present barriers to patients. So this is my reflection on this information, is for me to think, how important is it when I see one of these patients who has a bad social situation, they're not employed, other people in their family are addicted, they have medical comorbidities like hepatitis C, they're a young man from one of these ethnicity groups who I know is going to have a harder time for whatever reasons adhering to treatment. I'm just going to take all of those things that might make me think that person wouldn't be successful, or that I would present as something that they had to be accountable for, or a milestone that they had to reach early in treatment. And I would just try to ask myself, how important is that? Can I give that person time, and can I augment their resources or work with them to see if they might be able to be retained in treatment with a little extra TLC. From that shopping list of things that we would like our patients to adhere to before we would make the commitment to be treating them, there are a couple of those things that really do seem important. One of them is co-sedatives, alcohol or benzodiazepines. And this is a slide that just shows us, what the recommendations are around managing those, that we want that person to have an assessment if it's a prescribed medication, to look for an alternative, and to really be tapering off their benzodiazepine if they can. However, we've had some recent changes in our approach to this, where we used to think it's an absolute contraindication to prescribe buprenorphine to a person with a benzodiazepine, either a prescribed or an illicit one. We're now saying that buprenorphine shouldn't be withheld from those patients because it can make a difference to their opioid use disorder, and that we should instead address that benzodiazepine as time goes on. Cessation of use is preferred, especially if it's an illicit benzodiazepine, not prescribed, and we don't really know what it is or what the patient is getting along with it. And tapering is appropriate, but it's not absolutely necessary if the person is being successfully treated with their prescribed benzodiazepine and we can have some contact with the prescriber. So you may on occasion have a patient that you're co-prescribing or who's being co-prescribed benzodiazepines and buprenorphine. I have one such patient as a family doctor. It's a guy with panic disorder that I give some alprazolam to when he's having a procedure, and who gets buprenorphine from me. I've decided for patients that really feel that they need to have an ongoing chronic benzodiazepine, I want a psychiatrist to help me with that. And so those are patients that I would refer for assessment. There is some evidence for safety in co-prescribing, and this is the kind of evidence that led to that conclusion. If you're thinking about benzodiazepines, you can know that short-acting alprazolam, that Xanax, is the benzodiazepine most frequently involved in overdose, and we should generally avoid prescription of that, either by us or by a different prescriber. What about other drugs? The ones that we can, get excited by, like seeing cocaine on a person's drug screen. So here's some evidence that opioid-dependent cocaine users actually get benefit from office-based buprenorphine, like they're not dying of an opiate overdose, and that over time, they can be motivated to think about their cocaine use, to change it, and to actually focus on it and work on it, but often not before their opioid use disorder feels like it's controlled. And then the ongoing controversy, what about marijuana? Not enough data to know, is it going to be helpful or harmful? I think the sort of folk medicine approach, which seems to make sense, is that if a person has a substance use disorder, any substance that's going to change their mood and their mind and perceptions is a potentially addictive drug for a person, not a helpful medication. So at this point, we might advise people to not use marijuana, but it's commonly used in the methadone MAT population, and not a contraindication to that. And I think in our buprenorphine patients, we also see it pop up fairly frequently. So, again, even if it's obtained, even if a person appears to be getting benefit from it, if they're obtaining it illegally, it's still putting them at risk for some consequences. So it's one of those things where we really, I think, have to decide for ourselves what our threshold is at this point, because we don't have data to really advise us what our threshold should be. Those people with multiple relapses and treatment failures, we really want to define what we need by failure. What failed? Did they fail, or did we just fail not to provide them with what they needed? For example, people that say they failed a buprenorphine treatment, but their maximum dose was, say, 4 or 8 milligrams, or might certainly do better at a higher dose. People who need to have extra psychosocial supports beyond the ones that are required, and then the idea of planning more accountability for patients might be helpful. But I also, would think sometimes less accountability initially as the person's getting started might help to remove some barriers and some discouragement for them too. Relapse is common, and for us to have a plan to manage relapse to opioids, and for patients to know that they shouldn't just fall away and leave if they have a relapse, might make us think that we're having fewer treatment failures and more management of this sort of natural occurrence of relapse. Acute psychiatric comorbidities, well, go figure, these are patients that apparently have better adherence to treatment, possibly because they're used to having more care, they have more psychosocial supports from their psychiatric side. So if a person has capacity and they're not actively suicidal or homicidal, this should not be a barrier to us taking them into treatment. We might consider methadone, where there's more support and observed dosing, Sublocade, where a person doesn't have to decide to take their medication every day, or Vivitrol, which again involves no decision making about whether to take a dose or not, for those patients who might intermittently be unstable or not predictably be able to dose themselves. Coordination of care is the key for us around medical and psychiatric comorbidities, that we shouldn't have to be taking those on and feeling like we're having to deal with things that are outside the scope of our practice, or where we just need to share the load, and where the patient will benefit from getting these extra pieces of care. Coordination of care is especially good for people with poor social supports that don't have other family members to advocate them and to help them make their appointments. We're really thinking about building a virtual team for our patients and for ourselves. And it often is helpful just to have a patient start by establishing primary care, since the primary care physician really is going to know how to coordinate for those medical and psychiatric comorbidities. A little bit about office flow. We will recall that, part of our what we do in our office is governed by the requirements of our Ohio state law. That's 4731-33-03. Here's a link to those things. It doesn't work. When I want to read it, I just Google that and it pops right up, and you can refresh your memory about the 2.5 very dense pages about rules that we have to follow. But beyond just adhering to those rules, we want to have a stress-free visit that is within the scope of our practice, build a relationship with the patient, and develop some protocols that fit our own practice settings. So I think the kind of take home here is that if you have a templated note that prompts the things that we are required to have in our inductions and then in our subsequent visits, it makes life easier, that we're not having to remember what we need to do. And then it makes it easy to just go through looking at an ORS report, collecting our urine for our drug screen, documenting the appropriate counseling or meeting attendance that our patients are doing, a quick review of symptoms for withdrawal or sedation, and then having additional time where we can work with the patient around prevention or assuring that they're getting the other care that they need to manage the illnesses that are going to get in the way of them being in recovery. Between visits, you may or may not have time to spend, but these are some of the things that might come up. Prior authorization, and it helps to have a staff member to be able to do that. Lab results that come back and managing those. Sometimes we might wish to contact another provider for a patient to feel like we're coordinating more, and we really should be doing this around our patients' mental health care and counseling. Though honestly, unless the counseling is built into the program, it's sometimes hard to make those contacts easily. And then reviewing interim care as it's appropriate. If there's other things that a patient is seeing you for that are within the scope of your practice that you'd like to attend to, I have found in our whole hospital system actually advises us that it's okay to make separate appointments for those patients to attend, where we're really just going to focus on their other issues and not have to try to put all of the history, physical exam, and documentation for their opioid use disorder crammed into an appointment with other reasons that they have to seek care. In the big picture, what we find is that we're going to be consenting people yearly to review what they're supposed to be doing and what kind of progress that they've made. We're required to get some infectious disease screening when people do their intake, and we might want to review that depending on how the results are to ensure that people are getting the care that they need. And our urine drug screens and ORS reports will have a look at if there are trends there that we need to attend to over time. Sometimes rather than responding in a really dramatic way to a single aberrant finding, since we expect that people in early recovery are going to have those things. We will develop a relationship with the pharmacy just by, sending our prescriptions there and the pharmacy knowing that we're the stable prescriber, and then coordinating care. We have an opportunity to stop that revolving door where people come into treatment, aren't able to meet our expectations or their own expectations, or things aren't working out, leave treatment, and then define themselves as a treatment failure. Some of the ways we can help by accepting insurance and not creating financial barriers, by giving people some resources for solving their transportation problems and for being able to get to their appointments, for having realistic expectations about the required activities that we want them to do, which would include sort of disruptive random drug screens that we call people in for, or random pill counts. We might want to pay some attention to having a relapse plan should it occur, so that the person doesn't feel that a relapse is a cause for them to leave the program, and or for them to assume that they're not going to be able to get any further prescriptions from us, since they may have had that experience in the past. And then to think about helping patients achieve health and life goals as appropriate to the scope of our practice. Patients prefer buprenorphine. They prefer it to methadone, and they prefer it to Vivitrol, so that you can know when you have a patient, it's likely that they are where they want to be. And this is Grzinski et al. From 2013, telling us in their conclusion of their study of 80 patients, qualitative study, that positive experience with non-prescribed street buprenorphine were a central factor in participants' decision to seek buprenorphine treatment. It's one of the reasons people prefer it, because they've tried it and they know it works. So the conclusion for me is part of that revolving door is that if we see illicit buprenorphine on a person's drug screen, or they are endorsing to us that they've used that shouldn't be a reason for us to exclude them from treatment. When possible, we ought to be building bridges, not walls, building bridges to treatment and making it more accessible to people. And we know that over time, time will tell us and the patient if it's the right treatment for them. These are our references. You can find them anytime, and I'll send the things that I'm able to send over to Kay, should anyone wish to have access to those. And with that, I will try to stop sharing my screen.
Nice.
I
Thank you
think
so much.
Dr. Balster